Yeah, okay, so are we live?
Just a moment, sir. I'll give a count.
Okay.
Three, two, one. We are live.
Okay, good evening, everybody. Welcome to the fourth in our series of webinars on pelvic and acetabular fractures. And today we start with the acetabulum, essentially about the anatomy and radiology. So we are looking at the functional anatomy, the X-rays and the classification. And then I'll talk a little bit about the CT scans and how to read them, which can sometimes be confusing. So again, we have the pleasure to have Professor Kok-Sun Khong from Singapore, who will start the talk, with the first talk today, which is going to be on the functional anatomy, radiology, and classification of the acetabulum. So, Kok-Sun, over to you.
Okay. All right, my screen should be shared now. I don't think we're talking about the classification.
Sorry.
Time.
Okay, not today. Okay.
Next week. This will be a talk on the anatomy and the radiology, and I will stay on the radiology, and Dr. John will do the CT scan.
I think we've left a whole.
Right. Next slide. Okay, so the learning outcomes are that you have to understand the bony anatomy. It's the most difficult area to operate for the orthopedic surgeon, and especially around the acetabulum is a largely hidden joint. But you must know the relationships to all the vital structures within the pelvis. Okay, during this functional anatomy, I will try to tell you about the standard screw corridors and implant corridors, and then have an orientation of the pelvis in the operating room rather than seeing it on the standard anatomy diagram. You should learn all the standard radiographic rules and identify specific injuries, and then later on in next week's talk, there will be a classification exercise. And don't forget that you need the intraoperative imaging during surgery, unless you you have to use this to avoid mistakes by putting implants in dangerous areas. Let's start with the anatomy. The acetabular columns of this pelvis seen from the outside. First is a bisecting line between the crista ili, right at the top there, and the middle of the obturator foramen. In the blue area is the anterior column. In the yellow area is not the posterior column, we call it the sacroiliac buttress. The posterior column starts at the level of the sciatic notch. Inferior to that, in the back of the half of the acetabulum, is called the posterior column. These column displacements need reduction in order to restore the anatomy of the acetabulum. When you see wall fractures, it means there is a dislocation. So there is some instability unless you restore the walls. Undisplaced fractures for these columns can be treated non-operatively, or if they undergo secondary congruency with these columns, it is acceptable to treat them conservatively, perhaps with some light traction for a few weeks in bed. But you have to determine that from imaging studies. Now, I would like to bring you through the intrapelvic anatomy because it's the most important part, and with stoppa's approaches to the pelvis, you have to know what's inside the pelvis rather than what's outside. The quadrilateral plate hides behind the danger zone of the acetabulum, marked in red here. And where is it safe to put screws? Because you have to place screws around the acetabulum. So for screws that are coming in from the superior aspect, we call the brim plate, you can put screws behind or in front in the rami and in the sciatic buttress, but you must avoid the hip joint. If you use the intrapelvic plates, the screws are coming in from the inside and they're going laterally. There tend to be shorter screws compared to the longer screws of the brim plate because of the anatomy of the rami and of the columns. Here is what we call the iliopectineal eminence, and that is the only sign of where acetabulum is, and it's a danger area that you should try not to put implants unless you have very good imaging. In this model of a bicolumnar fracture, there is a pectinar eminence. We can actually place screws around them into the posterior column. In this diagram, you can see how screws can be placed behind the pectinar eminence and also in front. So these are pathways that you familiar with. For orientation of surgery, this is how the pelvis will sit in your operating table. It's not the way we normally see it on the anatomy books. The horizontal plane is between the same level of the iliac crest and the pubic rami. If you draw 45-degree alignment, where if you're passing a drill along these lines, 45-degree superiorly will delineate the pelvic rim, and 45 degrees inferiorly will delineate the line of the pubic rami orientation. The acetabulum is within this area. Of course, it's hidden if you are in intrapelvic. But the sliding knot, the obturator foramen is there. So injuries around here can affect the area of the obturator foramen. The screws that are placed in the rami, these are screws that secure your plate. They can secure the posterior and the anterior plate, part of the plate. But if you have a fracture like this is a T-type fracture, you generally try to close the ring in a triangle. Close the fracture in a triangular form. And with that, you can just simply place 3 screws as reducing screws. And then you can put your neutralization plate around them to allow further stability for weight bearing. This is a screw that you need to learn, an infra-acetabular screw, and it passes from front to back in the key part of the acetabulum. It can exit the bone in the papilloid fossa, but this is non-articulating with the femoral head, so it's got a safe place. Again, you need to have good imaging and know which kind of imaging to get this type of image. If you have another different configuration, like anterior column, posterior hemitransverse, that first screw may not be useful, the rami screw, and then you can change it and apply a inferior iliac spine screw into the back, and that's a very long screw, and you can just by changing configurations, you need to know what the fracture configuration is. Here's an example of an anterior column posterior hemitransverse fixation. The pelvic is a complex area, and usually this is a picture without any blood in it. And you see some bleeding, you will have the anatomy, you have to know your anatomy very well. The floor of the pelvis is covered by the obturator internus muscle, piriformis muscle, and the bladder and urethra. The pudendal artery supplies the pelvic floor, and the superior gluteal artery exits the first round into the sciatic knot. So all these areas are potential for bleeders. The ureter is seldom damaged, but in certain cases, you may want to insert a urinary in a retrograde catheter by the urologist to find it if you are going around into the sacroiliac joint area. The common iliac artery, of course, is pretty big, but you seldom see it in the intrapelvic or extraperitoneal approach. The internal iliac, external iliac are the branches of the common iliac. And the obturator artery is the closest you will see sitting on the obturator internus and over the quadrilateral plate, which is the back of the acetabulum. And the more important artery that you see between these two is called the corona mortis, which is a so-called aberrant vessel between or accessory vessel between the external iliac and the obturator. But it seems to be pretty common in some studies by Tonetta, up to 70 to 90% present in cadavers. What are the neural elements? And, you see these are the standard anatomy branches from the lumbosacral outflow. But we are interested today in the acetabular area. So at risk during acetabular surgery are a few of these nerves, the lumbosacral trunk and the sciatic nerve coming down, and then the pudendal nerve in the pubic rami. But more important anteriorly are the lateral cutaneous nerve of the thigh, which is just sitting through, above, or under the origin of the ilioinguinal ligament. As you do an ilioinguinal approach, you must look for this nerve. If you damage it, it may cause neuralgia parastatica. Then you have the femoral nerve that sits on top of the femoral iliopsoas. And again, these are a danger if you're doing approaches to the anterior wall. Finally, something that not often reported is impingement of the obturator nerve when trying to close the acetabular fracture, the T-type of acetabular fracture, and you may catch a nerve in the fragment here. But you can easily see it in the intrapelvic approach or in the ilioinguinal approach by having a finger move the nerve away when you are reducing the fracture size. So knowing the anatomy gives you the basics of acetabular fixation, which must be fulfilled to get an optimum outcome. Because it's a joint, you have to have accurate reduction, but you can accept some secondary congruence if your fixation is not too rigid. The first starts with the anterior and posterior column requires closure, so that is the bulk of the acetabulum. But to reach that reduction, you have to reduce the iliac crest first. Because sciatic buttress and anterior crest, if you don't match it, you may have distortion here, which then it's very hard to reduce this posterior column if you do not get the top of the brim right. Primary fixation is by leg screws, as I showed you in the previous diagram, but you need to have some sort of a neutralization plate in order to have early weight bearing. I always go for 4.5 screws. I think we discussed it last week. It's always stronger, and you can see that it's bicolumnar fracture. There's a minimal screw fixation. I just use two behind, one in the posterior column, and then one more or two more along the anterior rami, and that's all there is. And the power of the screw fixation is very high because the screws are larger diameter and they have a powerful reducing element. Okay, let's go on to imaging for pelvic acetabular trauma. Generally, I'm going to talk about X-rays, but you have to consider what they are. ATLS will allow the AP view of the pelvis to be taken as a standard view already, so you will probably have that when you see the patient in the ER. The Judet iliac oblique and obturator obliques are taken. I'll show you later. And we always do the pelvic inlet and outlet view to look for sacroiliac joint disruptions and ring disruptions. Dr. Mukhopadhyay will talk about the CT scans. And you also have to think about fast ultrasound and also angiography, urography, and duplex ultrasound for PVP. So in exams, you have to have all this in mind in the imaging. More important and practical to everybody who's listening is the intraoperative imaging, which is usually by C-arm unless you have a 3D fluoro, very expensive machine. So idea is that although you learn a lot about the CT scan, when you go into the intraoperative imaging, you only have a C-arm, and therefore you have to use the plain X-rays and study them to correlate with what you're doing in the OR. If you are fortunate enough to have a 3D fluoro, then the multiplanar scans will show you, you can repeat them on the 3D fluoro, but generally in many hospitals, we do not have the luxury. It starts with the trauma AP view, so you will probably get a picture like this with lots of foreign material. The trousers is not even taken off. But you can start with these X-rays provided they are nicely delineated, well exposed. There are 6 lines you need to see. Iliopectineal line, which runs under the top of the rami, and you can see on this side is broken. Ilioischial is the posterior buttress, from the ilium pelvic rim to the ischium. And again, you can see here, there's a disruption. Anterior wall is the line, usually quite faint unless you have a nice digital X-rays to manipulate. And the posterior lip or posterior wall delineates the rim of the acetabulum. The socio is the weight-bearing dome. In this case, there's some marginal infection in this fracture. And then you have the teardrop, which finishes off the picture. So you see rotational, you have a missing teardrop, means there is some rotational displacement of the acetabular. So when you see this anterior column, posterior column, social broken, then it has to be some sort of a fracture that involves both columns below the acetabular and nothing at the top. So it's probably some sort of a transverse type of fracture. So you need to you probably have a good idea as to what the fracture is before you even do the CT scan. The obturator oblique view is when the patient is tilted, if possible. If not, you may have to tilt the C-arm. But generally, you can get the person to have some sponges below that, even in the ER, to get a good view of the obturator oblique view. Here, the obturator is well seen. Sometimes you have this sort of picture where it's not easy to see, but you can easily make out the posterior wall, and also the fact that the head has been dislocated out of the acetabular. So this is a posterior fracture dislocation, a posterior wall fracture with a dislocation of the femoral head. On the other hand, the obturator oblique view will also give you the anterior column, and this is a fracture of the anterior column or the base of the ray line. In the iliac oblique view is the other way, about 45-degree tilt, and what you want to see is the posterior column. You may start off with a fracture X-ray like this, and you're wondering whether what is this central fracture dislocation of the hip, which column or which wall is involved. If you draw your lines, you will notice that the posterior wall, posterior column, ilioischial line is intact. The iliopectineal line is disrupted. The anterior wall line is disrupted. So it's some sort of an anterior wall fracture, and this is confirmed on the iliac oblique view, where you can see that the posterior notch is quite intact. The anterior wall is disrupted, but the posterior column is intact. Alternatively, you can see this picture where there is a break in the posterior side, greater siding notch. So this is actually a minimally displaced posterior column fracture. There are other unique radiographic signs. One of them is a spur sign, and you can only see it on the obturator oblique view. It's a spike outside the acetabular brim. And what is the cause of this? Well, because you're taking an oblique view, you're wondering which color, what is the cause of the spike? The spike is caused not by the broken iliac wing, but actually by the intact iliac wing at the back, the posterior iliac wing. So the spike is actually the posterior iliac wing, and the iliac crest is displaced iliac crest will be moved forward, and therefore the spike is seen in the posterior aspect. But you can only get it through the oblique view. And this is a pathognomic sign of an associated column fracture. Another unique radiographic sign is the concept of the roof arc measurement. If you have a fracture like this, a transverse type fracture with a T perhaps, you want to see how much of the dome is weight-bearing coverage is being preserved. So you require the AP, oblique, obturator oblique, and the iliac oblique views. And you draw something opposite to what we call the CE angle for this location. We call it the center to the fracture line. If it exceeds 45 degrees, you will have a low transverse fracture. If a high transverse fracture less than 45 degrees, then there will be a high risk of displacement without surgery. So if it's very low transverse fractures, some may be treated without secondary osteoarthritis. So it is a consideration for non-operative treatment. In the OR, you have these views. I find this a very good view. It's the obturator oblique outward view. So it's like a OOO view or triple O view. It's an outward view, so you are about 30 to 45 degrees from the midline, from the vertical. And then it's tilted 30 to 45 degrees in oblique position. So it's called an obturator oblique outlet or obturator outlet oblique. And what you actually want to see in the profile is actually the rami, anterior column rami. And that's how you place a screw either from the back to the front or front to the back, as in this case. If you shift it up into this area, you will actually see the position here, where the sourcil of the head is. And this will give you the supra-acetabular screw position. If you choose to put a screw in there, or perhaps a low root external fixator pin can be placed right into here. If you enter in the center of this teardrop, so-called teardrop, you will be totally in bone, and you have a very long pathway for your your supra-acetabular external fixator pin. You can put large ones in there. But if you're doing X-rays, this is the view to take. Obturator outlet. Also, other reasons for doing X-rays in fluoroscopy in surgery, of course, is to see in checking reduction of fractures. So a transverse fracture like this, and if you're doing manipulation and using tools, you want to have a good reduction. You certainly will have to do this before you place any implant. In the outlet view, again, if you want to see the quadrilateral plate, this is the outlet view, it's the best view, it's an AP outlet view. And also you can see the wall, posterior wall line up. So posterior wall and quadrilateral plate lines up. This spring plate has reduced its fracture laterally. In the iliac oblique view, an example would be a bicolumnar fracture. And the initial reduction of the supra-acetabular portion of the iliac ring portion is by a simple surplus wire. You can get this in the iliac oblique view. Of course, this has not been reduced, which has to be a second step. And finally, checking the joint for implant positions and reduction. You can see that in this head fracture with headless screws inside, you can see a nice joint. And then the hook plates are all outside the joint. And so is the neutralization plate. So these views are again repeated within surgery, so you have to learn them. So the take-home message is be familiar with the bony anatomy and soft tissue relationships around the acetabular. Learn these pathways for your passage of screws and plates, and you can use these safe pathways without getting into trouble with all the soft tissues behind and around the acetabular. Develop in your own mind a systematic method of image analysis, which will of course include plain X-rays, which is always essential before you send the patient to CT scan. Then correlate with a CT scan for your pre-op planning. But remember that within the operating field, you generally only have fluoro images, which are two-dimensional, and then you have to, in your mind, interpret them to prevent any complication or implant malposition. Thank you very much for your attention.
Thanks, Kok-Sun. That was great. Some very precise, and some of the animations that you produce are absolutely out of the world. So you need to teach us that in one of the webinars.
Well, it makes for better understanding of the
I know, but it's, yeah. Okay, any questions, Janki, before we go?
So there is one question which Kumar Gautam has asked for the role of MRI in acetabular fracture.
In fresh
Do
cases.
we have, sir?
I think MRI we discussed before in the emergency situation. It's very hard to do an MRI. You might want to consider in a suitably delayed situation where the patient is not on life support or requiring any, not in an extremis or anything. So you're just looking to see if you're thinking that perhaps with a fracture of the neck or femur, together with an acetabular fracture, you want to see whether it's viable, then perhaps that may be useful. It is not so easy to do an MRI in a traumatic patient because motion artifacts will sort of spoil the images and it's not precise enough. I think the CT scan is the mainstay of trauma?
Yeah, definitely for the initial management. I think there may be some unusual situations where you may have to occasionally rely on them, but usually it's just X-rays and CT scans. So yeah.
One more thing, sir, which I want to ask is that about the acetabular roof, dome, and sourcil. All the three same, sir, or is there something different? Is the weight bearing portion, yeah? Acetabular roof
What is your question between the dome and the sourcil?
and acetabular roof. What is the difference, sir? Is it same or
Same.
something different?
The sourcil is the area, the sort of the triangle above the weight-bearing dome. For this dome is generally up of 45 degrees. That's why Mata gave this 45 degrees. So it subtends an angle of about 90 degrees of the dome, which is of course something more like 200 or 250 degrees. That is the weight-bearing portion. But again, it depends on your orientation. If you get your orientation right, then it is a true weight bearing. Otherwise, it could be a bit on the posterior column or inferior column, depending on how your images were taken in which plane. But the sourcil is a totally bony area. It's a supraacetabular area in a sort of a triangular configuration.
Yeah.
So,
Great.
So that is the weight bearing portion. All the three is same, sir. So another thing, sir, about the cotyloid fossa or acetabular fossa. Is it same, sir? Both same acetabular fossa and that cotyloid fossa. What I understood is that non-articular portion.
All right. The articular portion is a sort of a horseshoe-shaped area. So deep to that area is where the ligamentum blood supply that follows, and there's some fatty tissue there. And the pulvina, you may say so in pediatrics. That area is a non-articulating, is the cotyloid fossa.
So, sir, whatever the horseshoe area is covered by labrum or fibrocartilaginous tissue, that is only the articular portion, sir.
No, it's not
No,
covered
no,
by labrum. Labrum is along the periphery.
Periphery.
Okay, sir.
Yeah, there's only a transverse ligament. There's a transverse ligament there, which
The inferior part.
When we do our hip replacement, we place that double prong inside. Yeah, that's the only one. And it's
So if you look at the acetabular anatomy, the part just below the cotyloid fossa often tends to be slightly deficient, okay? And that's where the transverse ligament crosses. Now, sometimes that gets filled with bone because of osteophytes, etc. But usually you have a slightly deficient area there.
So the ligamentum teres, which is existing on the femoral head and getting attached to that fossa only, sir. So because of that, it is non-articular. Okay, sir. And one more thing which I just want to ask, sir. So when we say it's like impaction or that gull sign, which probably sir will explain in his talk. So in that one, sir, the roof or weight bearing portion is getting, or is it same?
No, no. So impaction is different, and a seagull sign is a sign of dome impaction. Okay, you get it when there's dome impaction. While if you have a posterior wall fracture with impaction, that's not, you don't get the seagull sign there. There you need to study it on the CT. Okay. And the seagull sign is a radiological X-ray finding, not a CT finding.
So it's on the X-ray. So and one more is thing, sir. In because of on the basis of X-ray, we decide in which patient we should put traction preoperatively, and in which case we should not. So what is the criteria of putting preoperative traction, sir? On the basis of
for an X-ray or CT scan or in general?
In general, sir, like on the basis of radiology, when patient comes in the emergency, and in few cases it is important to put traction. So what are the
I would say the traction is in any dislocation.
Yes,
Whether it's a
luxation or
posterior
dislocation.
dislocation or a central dislocation, it's always good to put traction because that sort of brings the head back and reduces damage to the cartilage. Of course, there's such a thing as longitudinal traction and lateral traction and all that. But if you are thinking of initial management or first aid for a dislocated hip or fracture dislocation of the hip, traction is always useful.
so there are few more questions in the chat box. So I think after the talk we can continue.
Sure.
Yeah.
So do you want me to share my screen?
Sir.
Okay, so good evening, everybody. Today we'll talk about CT scans. And I have to acknowledge Dr. Paul Grutzner from Germany, who gave a talk on this in Bangalore some years ago and was kind enough to lend me some of his slides, which I have used in this talk. I think it's important that diagnosis is key to the management of any acetabular fracture. And it's initially based on X-ray films, but you need the CT scan to get more details, as well as the volumetric analysis, which the 3D scans gives you a good overall picture of the entire injury. Now, hopefully by the end of this talk, you would be able to have a systematic plan to read your CT scans, know which cuts are the most useful, look for additional information available on the CT, which you may not be able to get on the X-rays. And eventually your combination of your X-rays and CT scans should allow you to come to a decent diagnosis, which will help your management. Now, when you look at the axial cuts that you get in these CTs, you get a whole series of cuts, and it's sometimes confusing for people to really understand what they're looking for. And similarly, in the transverse and sagittal cuts, you've got this whole list of pictures there, which you are wondering which one do I look at, how do I interpret it? So this is where this idea of doing some standardized cuts where you look at particular levels and look at what there is to decide on how your fracture pattern is decided and how you would diagnose and manage your treatment, your patient. So I think these are the 8 cuts which Dr. Grutzner talked about. You can do other cuts. So you can use this as a guide to decide, okay, I want a cut at this level, but you should have an idea that on the CT, these axial cuts are going to go through in this direction and will show you these structures. Okay, so the first standardized cut in this 8 cuts that he talks about is at the level of the anterior superior iliac spine. Okay, so that's the anterior superior iliac spine. And remember, the pelvic is oblique, so this also goes through the lower part of the SI joint. So it will help you evaluate problems in the SI joint and also high fracture lines in the 2-column fractures. So a lot of the the 2-column fractures exiting high in the anterior column will go in this area. And so this CT scan would help you in looking at those fractures. The second slice is at the level of the anterior inferior iliac spine. Okay, so now this is just above the acetabulum, a short degree of a few centimeters above the acetabulum. And this is useful for assessment of involvement of the columns and also for transverse fractures. Okay, so it's this scan and the one just below this, which I'll talk about, where you look at the scans to look at the trying to decide whether it's a column fracture or a transverse fracture or a wall fracture. Okay, so the anterior column fracture will be a transverse line. So this is what, if you understand the anatomy, is the column fractures which are going in the direction which is horizontal on the CT scan, while the transverse fractures will be going vertically. Okay, so that's how you decide that this is a fracture line which is actually going transversely is a column fracture, and one that is going vertically is usually a a transverse fracture. The one that goes horizontally is a column fracture. Okay, so this shows you the anterior column fracture. You can see the vertical lines there, and you can see that it affects in this area. So a section just above this area should show you where this fracture line comes out in the anterior column. The next section, so this is to show you in a case that we had. So this is the level that you would have it. You can see how the anterior column is involved in there. And if you look at the 3D CT scans, it shows you how the anterior wall is involved in, anterior column is involved in this level. And it also shows you that this fracture actually also goes into the posterior column, but it's not very displaced. It's just a crack line going through to the posterior column. It also helps you in the transtectal fractures, which is the high sort of transverse fractures. The third slice is actually at the level of the acetabular roof. And this is actually the best area to decide on whether the fracture is a transverse fracture, where you'll have a line that is vertical, or a column fracture where the line is transverse. Okay, and you will also help you decide on anterior column and posterior hemitransverse fractures, where the anterior column is involved and you have a hemitransverse fracture. So here's an example of that. This is the CT section at the level of the roof of the acetabulum, and you can see how there's an anterior column fracture and a posterior transverse element to the fracture, so that it becomes a anterior column and posterior hemitransverse. Of course, we'll be going into more details on the classification next week. So these are just to mention what are the things. The other things, so this is at this level, if you have a vertical line, it's a transverse fracture. Okay. Vertical line, it's a transverse fracture. If it's a horizontal line, it's a column fracture. And the wall fractures will actually show as oblique lines, as you can see in this diagram. So the posterior wall and the anterior wall, and that's best seen a little lower, more in the main part of the acetabulum, the wall fractures. And the column fractures are best seen in the direction that we talk about at the level of the roof of the acetabulum. The fourth slice is through the largest diameter of the acetabulum and femoral head. Okay, so right almost in the center of the acetabulum. And as I mentioned, this is where you can see the anterior wall and posterior wall fractures, which are usually oblique lines. Okay, it also allows you to assess the affection of the anterior and posterior walls and subluxations and dislocations of the femoral head. Okay, so this is showing you a posterior wall fracture at this level. Okay, so if a section goes through here, it will show you this posterior wall fracture. Here's an example of a section through that level. This is through the maximum diameter in the axial cut of the acetabulum. And on this side, you can see there's an intra-articular loose body, a posterior wall fracture, and a subluxation dislocation of the head. Okay, and the same patient, the 3D CT scans showing you that there's an posterior wall fracture with subluxation, and also possibly a line extending undisplaced fracture involving the anterior column. The fifth slice is at the inferior margin of the acetabulum. This line shows it a bit below that, but around this level. And it will show you the inferior margin of the acetabulum as well as the affections of the superior and inferior pubic rami. Now we come to the coronal cuts, and there are two important coronal cuts. One which goes through the largest diameter of the acetabulum slightly, so it'll be roughly at this level, and this is how it will look like on the CT scan, and it will give you the ability to assess the anterior column from the iliac crest to the pubic bone, as well as the acetabular roof. So you can see the anterior column as well as the acetabular roof very clearly. Okay, so again, here's an example. This is like more centrally impacted fracture, but again, you can see the column involvement anteriorly there, and again, the CT scan showing you the level of the fracture and the displacement. The next important coronal film is the view of the posterior column. So more posteriorly, when you do the it shows you the entire posterior column in line. Okay, so that's the slide 7 in the standardized CT scans. And this shows you the posterior column. And again, here's an example. Again, at that level, you can see the entire posterior column in this area. And again, the fracture involving the column here. This fracture also involves the anterior column, but you can see the low posterior column fracture that is a transverse element of the fracture. Okay. And the last scan that you look at is the sagittal view in the largest diameter of the acetabulum. It's almost the central sagittal view of the acetabulum. And this actually allows you to assess the anterior column, anterior wall, posterior column, and the congruency of the acetabulum and the roof. Okay, so all these things can be seen. This is the section that you look at. You can see the anterior part involved, the posterior part involved. And again, the 3D CTs, corresponding 3D CTs showing you the whole picture of the injury. Okay, so there are some other slices, sorry?
Sir, there is some disturbance in the noise, sir. Some background, probably the mic position may have.
There's nothing, no noise here.
No, sir, echoing from probably the wires is getting.
Okay, let me just adjust that. Is that any better?
Yes,
Maybe
sir.
take off the, is that better?
Yes, sir. Fine, sir.
So maybe it's the earphones that were creating trouble. Okay, sorry. So there's some other slices which are useful. One is at the level of the pelvic rib, which will also give you an idea of the sciatic notch. It's roughly at that level. And also at the level of the inferior pubic ramus. And that usually corresponds with the lesser trochanter here. Okay, so these are the sections that you can look at. The other thing that CT scans will tell you, which are difficult sometimes to tell on the X-rays, is we talked about intra-articular fragments. Okay, so you can see the intra-articular fragment here, apart from the posterior wall fracture. You can see the femoral head fracture. Again, once the head is reduced, it may sometimes be difficult to make out the head fracture on the X-rays. You can also judge the size of the posterior wall fracture more accurately than in X-rays and get an idea of the instability. If you see that it is subluxing posteriorly because of the fracture. And marginal impaction, which we talked about, you can see how this part of the articular cartilage is impacted into the acetabular sort of bone. And unless you elevate it, you will not get a congruent reduction of the joint. You also need it to look at the posterior elements. Okay, now even in an acetabular fracture, you can have a combined pelvic injury, especially the posterior elements, the sacral fracture, etc. is something which is again difficult to see on the X-ray. So the CT will help you sort of decide that. Okay. Once you've done all these, you can also, if you have, as I mentioned last time, the console with you, it's a nice thing to run through it from top to bottom. You start above the pelvis, go through the iliac spine, go down through the acetabular area and down to the pubic rami, and you can get a very good idea of the fracture pattern if you have the ability to do this in your own hospital. And finally, you have the 3D reconstructions, which today are fairly nice to look at. They give you a very good idea of the overall fracture position, the fracture line. So you can spin this around and look at it in different directions to actually see the entire fracture line. And you can also subtract the femoral head so that you're looking directly into the acetabulum. So these are images with the femoral head subtracted. So you can see directly the fracture lines going inside the acetabulum very clearly without the femoral head getting in your way. So if you get all these images together, it will give you a very good picture of what you're dealing with. Okay, so to take home, I think it's important, as was mentioned in the previous talk, to have a good knowledge about the anatomy. I think this is essential if you're thinking about operating on these fractures. You still need plain X-rays. Again, this was alluded to in the previous talk. Partly for training, I think your diagnosis of these fractures, and we'll be going through that next week, and how you diagnose the fractures and how you look at different views of the X-rays to tell you which part of the column or wall are involved. And also, as was mentioned earlier, most of us in the OT only have C-arm images to look at. So the CT is difficult to reproduce or recreate the anatomy based on the CT unless you also have an idea of the X-ray picture. I think, as I mentioned, CT scans are really essential for certain details of the fracture, which help you in your management. And the volume rendering 3D images really help in understanding the overall fracture pattern. But for real details, you actually need the 2D scans to give you the sort of actual things like impaction, etc., are much better seen on the 2D scans rather than on the 3D pictures, which tend to kind of make it a little more blurred in terms of local details. So I think I'll stop there, and whatever pending questions and questions on this talk we can take now. Thank you. Okay, so
I've answered some questions in the chat group. Are there any other chat?
Okay, great. So Janki?
Anything coming on your mobile?
I actually haven't got my mobile connected. Because
Janki is mobile. He usually gets questions.
Janki gets questions. Okay. So anyway, so Janki, questions?
One thing I was mentioning about the CT scan is actually good to draw these lines on a plastic model.
Yeah, I was going, yeah. So eventually, once you've done all this, then if you, especially in your initial days, actually draw out the lines on the plastic bone model that you have, and then actually keep that in OR with you and look at it. That's a very useful practice, especially in the beginning of your journey into acetabular fracture surgery.
Yeah.
And also for me, I train the residents to bend the plates, learn to bend the plates. You decide where you want to put the plate, then contour the plate. Sometimes I know you don't have the full set. So you pick a plate from your set, contour it, and autoclave it before surgery. And you just have to do some minor adjustment on the table.
This is especially for the sort of buttress plates for the quadrilateral plate, but now with the newer approach, it's less often used. With the Stock's approach, you tend to buttress it directly, so you don't need to do that.
Some are preformed plates. They are already
and they have preformed plates which you can put in from the top.
The other thing is also have a little note about whether you're dealing with a female or male, because the pelvic brim has some sort of curvature changes. Some are more gynecoid and some are more masculine type of pelvic.
Absolutely, yeah.
But not too big an issue.
Yeah, because most of the plates we use are quite malleable, so that's one of the good things. We don't tend to use very stiff plates in the acetabulum for that reason. So because you need to mold your plates, and plus when you tighten the screws, you expect the plate to adapt to the anatomy.
Yes.
So in acute settings, sir, when patient comes, when we do not know is it a pelvic fracture or acetabular fracture, is it ideal to go for AP X-ray and then decide, or we should take AP, geodet view, inlet and outlet view all at one go?
In our situation, we take 5 views.
So if the patient comes in as an emergency in with major injury, then you would just do the AP to start with. But if he's coming to in a stable condition, then you would investigate everything. Yeah. So I think for the acetabulum, it's also, I mean, maybe with CT scans, it's again may precluded to some extent, but by and large, if you make it a habit that you get all these views, you won't miss it. Otherwise, every now and then you'll find that some view has not been taken because the resident felt it wasn't necessary. So it's good to make it a protocol, as Kok-Sun mentioned, to take all 5 views.
Yeah, because the radiographer is already there. So just to position the sort of a mobile machine, he just takes 5 views, he just goes away. Otherwise, you got to call him back again, and then he's somewhere else in the ward and all that.
Yeah.
So,
I mean, we've had many times when in the initial X-ray, you can think it's just an acetabular or a pelvic fracture, and when you get the other views and CT scans, you find that it involves pelvis and acetabulum. So that's something you should have an idea about.
And so, how to know that Juret view is taken perfectly? Because we do not know, in when we are taking obturator or iliac view, how to know it is okay.
So you go by what it's called. So what is an obturator view?
That obturator is seen completely.
Yeah, so you should see the obturator foramen in full profile, and similarly, in the iliac view, you should see the iliac blade in full profile. Okay, now typically how it was described is with the patient being tilted. Now, obviously in OR you can't do that, so you usually tilt the X-ray machine to get your angles.
And so sometimes it is not possible to take Juret view because of pain, more pain in that area. So in that case,
so you can tilt the views, but it doesn't give you the absolutely exact picture. Yeah, Kok-Sun, what's?
Yeah, I mean, actually, if you have a draw sheet under the patient, you can just lift up the draw sheet and then put in a wedge, radiolucent wedge. Most of the radiographers carry this with them in the machine, and then you just put the other side or a towel. You don't have one, just have a towel. But it is good to do it. Sometimes you may have to do it like in the OR when the patient is undergoing some laparotomy while it's being induced, and you have already have the C-arm. You can do it just to get a screenshot rather than a full X-ray machine. But you have to have a good exposure, good machine, and the one thing about positioning the patient on the operating room table is very important. Because of the inlet-outlet oblique views, you've got to put the patient near the bottom of the table if you don't have a radiolucent table. At the tail end, so that this machine doesn't, you get the full angle, otherwise you want 45 degrees, but you find the bottom of the machine is hitting the pillar of the table and things like that.
Especially for the outlet view, you will not get the room for the bottom of the machine.
That's right.
And, so what we do is we actually use a radiolucent extension to the regular table, because and we keep the patient lower down than we would normally.
Yeah. And tie a drip stand to the bottom to shaking. Yeah.
So in your talk, you have mentioned one transtectal fracture. So transtectal, infratectal, what is that, sir?
So when you talk about transverse fractures, they can be transtectal, juxtatectal, or infratectal. Okay, so that depends on the level of the fracture.
That is type of transverse fracture.
Yeah, there are 4 transverse fractures. The transtectal is almost at the level of the roof. Juxtatectal is just below, and the infratectal is generally off the weight-bearing area. So those are the ones where sometimes you can treat conservatively.
They will be covered in the T-type and transverse fracture lecture.
And so, what is because you have mentioned in the pelvis also that 2D CT and 3D CT both is important. So in what we can miss if we do not take a 2D scan?
So things like marginal impaction, okay? You will not see that on the 3D, even with because it gets a bit generalized. View doesn't give you all the details sometimes. All the fragments will look like one coalesced piece of fragment or whatever, pieces of fragment rather than the exact position. Again, in intra-articular loose bodies, okay, especially a small loose body. Head fractures, if it's not head fractures, you'll see on the 3D also, but sometimes once you've reduced it, sometimes it actually gets reduced quite well. and then the 3D might just not show it very clearly. Okay, so.
Well, the 2D is always taken first.
Yeah.
The 2D axial cuts are always standard. Then you get the coronal, the sagittal, and the 3D built in as a program, which the radiographer will then just key in. So you actually get all the studies. Whether you don't choose, I want only 3D, I only want 2D.
Yeah, so to get the 3D, you have to have done the 2D.
It's all in a package.
Yeah.
Actually, sir, what happens, sir, because most of the residents know how to see the 3D CT, but for 2D, if they do not know, then what they can miss, that we should.
Yeah, so that's why it's, and also to understand the fracture, okay? So
yeah.
If you look at the 2Ds, you get a much better idea of what's happening. But only thing is, like, you need to, because you get so many images, if you don't have that, the console to actually go through it, it's sometimes difficult to understand what part is affecting. So it's good to have some standardized levels that you look at, and then you can draw it onto your pelvis.
So when taking the CT scan, do you also explain the radiologist to how much section means how much thin section we should take for acetabular fracture?
So always do the thinnest slices the CT machine can do for you.
Yes, sir.
The slices should be within 2 millimeter to 3 millimeter. Yeah. And there should be some overlap if possible, because if you want a good 3D image, you must have a 1 millimeter overlap of the slices.
Yeah.
So the dial is in. So if you, the difference between a CT taken as a trauma CT, that means a helical CT from head to foot, they give you big slices, 4 or 5 millimeter, because they're looking for big things like
major trauma, major
hematomas and things like that. But you got to repeat the CT again for a pelvis or acetabular for your pre-op planning. You cannot use the original thick slice CTs.
Absolutely, because you need detail, and so the thinner your slices, the more detail you get.
Okay. CT is very fast. Whether you use 3 millimeter, 2 millimeter, or 1, it goes through in.
Yeah, especially with the newer machines, it's very quick.
3 minutes and it's all done. Yeah.
So again, this is very important, not just for the acetabulum. We're talking about proximal tibia, distal tibia.
Yes.
You miss things if you don't get thin slices.
And so when we are doing the fixation, like you have taking the dynamic X-ray like CM pictures after the fixation, that screw should not be in the joint. So what all view is important to know that one, sir?
The intraoperative fluoroscopy.
Yeah.
Yeah, the same views. The same views. What you basically want is a tangential view to the joint. If you want to see the posterior part of the joint, it's an iliac oblique view. You want to see the anterior part that's tangential, is the obturator oblique view. So this has all been studied by Jude for many years. That's how he came up with his classification, because he used oblique views, and then he delineated all the fracture patterns from good X-ray. Because before that, they just do an AP view, and then they said all fracture dislocations are one kind. Then after doing these views, he looked at the anatomy and he decided this is a column. So this is the anterior column. So from there, he devised the whole information that we now use as a classification for acetabular fracture. So use the same views. You may decide to tilt it a little bit in order to see, or you push the patient a little bit, or you move hip joint or the move the femoral head a little bit in certain areas, but that is while the fluoro is in the standard position.
So even when we are doing the surgical approach, or even when we are doing minimally invasive, we are more worried about the corona mortis. So what is the exact position of that, sir, when we are opening the through the surgical approach, or even when we are putting the screw?
Oh, it's just before the obturator artery exits the pelvic rim in the obturator foramen, which is on the lateral side of the quadrilateral plate and also just inferior to the root of the superior pubic ramus. So the vessel lies in that, but it is also protected by the lacuna ligament. So unless you split the lacuna ligament, sometimes you do not actually see it. And sometimes you can feel it, but it's sometimes a vestigial amount, so it's a very small amount.
Yeah, so the interesting thing about the corona is that when you're doing the ilioinguinal, you don't see it very often. But when you're doing the stoppas, you almost always see it and to either ligate or coagulate it.
Because you're looking at it from inside out.
Hang on to it while there you're at the top, and unless it's a major vessel, it doesn't bleed too much. If it's a very tiny vessel, it doesn't bleed much, and you're not looking for it particularly. You can feel for it. I think Latunal did advise that you should feel for it to see if there's a big vessel there or not.
Sometimes he used to put two plates, sir, one on the anterior surface and on the one on like in the stopa approach. So on that one, sir, on that surface, because there are few arteries, probably that is corona mortis only. So when you are going through, when you are approaching through that one, how to avoid the injury of that one, sir? Because the plate is going on that surface.
So in the stopper approach, you always look for the corona and ligate or clip it and divide it, okay? So it's actually not, in fact, what is more of an issue is the obturator nerve and the obturator vessel also. So sometimes some people actually ligate the obturator vessel if it's getting in the way. But you can't do that with the nerve. So the nerve you have to protect.
Yeah, if you ligate you can actually put the plate right on the top of this. It's not the main supply unless you cannot find the obturator artery. Then the corona mortis is the main supply of the obturator. Yeah. But that's very rare. I've never seen it.
So one question which just now comes from Manu Singh Punjab is that life expectancy after hip fracture. Probably you want to know about the acetabular fracture or fracture around hip. That is.
Okay, so this is
acetabular fracture.
Yeah. What is the life?
Neck fracture or?
Well, he says hip fracture. It doesn't actually. So I think so you're presumably talking about elderly hip fractures where you may possibly could include acetabular fractures almost into the same bracket. Okay. So I think if you look at studies from even places like Mayo Clinic, the 3-month mortality in the elderly, okay, now this is not for a 50-year-old or a healthy 60-year-old. But for the elderly, frail patient, it's close to 30% at about 3 months after these fractures, 25 to 30%.
So one question which is actually answered by Kok-Sun sir, and usually most of the postgraduate is confused about that one, is teardrop. So can you slightly in brief, sir, so that it is easy to understand for the postgraduate?
The teardrop is actually the articular surface, the horseshoe. Okay, do you know when you look at the acetabulum, there's a horseshoe. At the lower part, the horseshoe is not this way, it's this way. So you see my hand is like a teardrop now. Can you see when I like this? So when the horseshoe at the inferior part is rotated, it looks like my hand, a horseshoe. Whereas if you look at it like this is the horseshoe coming down, and then it starts to turn in. As it turns in, you see my hand, this part is the horseshoe. Okay, that's the best I can tell.
Yeah, so there are a lot of people who, I think a few explanations for me, including that it's not actually anatomical structure, but a radiological image. Okay. In that, what he's talking about is the region for sure, but it's actually a image that you get on X-rays. It's not actually a radiologic. There's no structure called the teardrop actually there.
It's a mirage. But the reason to know where what the teardrop is when you put that infra-acetabular screw,
Yeah.
you must be medial to the horseshoe. If you are lateral to the horseshoe, you are in the joint.
Yeah, it's also important in arthroplasty surgery because it tells you where the medial
The
end
floor.
ends. Yeah. Joint.
Sir, you have during the talk we have seen there are two signs. One is Gull sign, and another one you have mentioned in that bicolumnar fracture.
Spur sign.
Spur
Spur sign. So other than that, there is no other sign also for acetabular fracture.
You mean
If you're looking for
other
signs,
special signs?
Sorry, sir.
You mean name those
signs.
Yeah.
name signs? No. I think you must not understand what they mean.
Yeah, that's
So
more.
here, spur sign is a bicolumnar fracture. But it's not a spur that goes up, it's a spur that must come down. It's a coming down spur, not the going up. Going up spur is the wall of the acetabulum, posterior wall.
Yeah, that's true. I think, there are two Gull signs. One is the dome impaction. The other is in the sacral side, sacral fractures that you see. Okay, or you should.
And this
it should not be disrupted in the sacral fracture.
As a sacral foramina.
Foramen, okay, around the sacral foramina.
So, sir, for the spur sign, we should see the iliac view X-ray because that is the lower portion of iliac.
Obturator view.
Obturator oblique.
Okay,
obturator.
And for
I showed you in the diagram the beam angle is a 45-degree beam because the fragment is posterior, so you can only see it end on at the 45-degree, and you see the posterior iliac wing. So that the first sign comes on the posterior iliac wing.
So it is actually the intact posterior part of the iliac bone. Okay. It's not the fractured portion of the, and not the displaced portion of the fracture. Yeah.
And which is view is best for Gull sign? It is AP view, sir.
Say that again.
Which view for the
Gull sign?
Dome impaction.
Yeah.
Dome impaction is seen in all three views.
You'll see that in
all three views.
In the obturator iliac, and you can see it in the iliac view as well. And it to some extent depends which part of the dome is impacted. That will show more clearly on one view.
Yeah, I just share my screen for now.
Yeah.
Can you see what we mean? This yellow line, can you see my screen?
Yes.
Yeah, so this yellow line is a spur. It can be sharp or it can be blunt. It doesn't matter. It depends on the fracture pattern. So usually like this is sharper. So this comes from the posterior iliac wing because this has displaced medially. So that orange line, which is the anterior column, and there's a split between these two. So that means there's a bicolumn. The split is from the iliac crest all the way down, and then you just have two pieces moving apart from each other. Can you see that when they split? So the one of them becomes a spur. So this one becomes the back becomes a spur. Then the other one is you were talking about the marginal impaction.
Yes.
I'll try to get okay. So when you see this, marginal impaction comes when you see the Gull sign. You can see depending on where the impaction. It's just a double dome on this. Double dome. This one doesn't have any marginal impaction. So you can see it on in any of these three views. So they're always the three standard views. You can pick them up.
Yeah, we'll show that. Okay. So.
And one more thing, sir. Just one question about that roof arc. How much important it is, sir? Because even now you are using to decide the method of treatment for deciding factor for the method of treatment in acetabular?
I think there's been some modification. I think they were mentioning there was some modification.
So Tuneta has modified the Matas angles. So you're looking at different angles in different views. So, okay. So the posterior part is more important than the anterior part. So you need when you're looking at the posterior part of the roof, you need a 60-degree angle. Well, in the anterior part, you may get about 30 or 30. I can't remember the exact numbers, but it's a modification. It's no longer 45, 45, 40. But the main idea is that it tells you which is the part of the dome, the weight-bearing area, which is not fractured. Okay, so those are unlikely to have significant osteoarthritic changes with conservative treatment. Okay, because if that part is fractured and the hip joint is moving in that fractured area, you're going to get osteoarthritic changes.
The main thing is to decide if it is possible to treat
these patients.
if you are not going to operate on them. Because these marginal infections are again not easy to reduce.
Yeah.
Intra-pelvic and push them out. So if you don't need to do that, perhaps there may be an indication in certain kinds of patients to leave them alone, and you can use that this roof out angle to justify your treatment.
So the other thing is that, as he has mentioned, that you can get these patients up reasonably early because the main part of the dome is intact. You also have a CT measurement of the dome. Okay, I think it's 10 millimeters or something. If it's 10 millimeters is intact, then they say that it's a intact, adequate roof arc angle there. Because CT is looking like that, so you can't measure angles. But you see, if 10 millimeters of the roof is okay, that means it's about 45 degrees.
The other thing you can do you can use a dynamic fluoroscopy. So when you get the patient in, you get your three views, okay, AP, II oblique, and the obturator oblique, and then you move your hip. So these are transverse fractures, but they tend to medialize, moving to the center. So by abducting the hip, and you want to see whether the head will engage, and if it leaves it, that means it's a dynamic instability. So the roof out angle is a static picture, but I often do dynamic fluoro to look at instability rather than what covers the head.
Yeah, you also do that instability test for the posterior wall fractures sometimes if you decide whether you need to operate on them or not.
So, sir, what you have mentioned about the 8 to 10 millimeter, that is, we should see the 2 millimeter section of this cross section from up to down, and we can count it 4 or 5 like that, no, sir?
Yeah, depending on the size of your slices, you need to look at the upper 10 millimeters.
So there is just one last question from the Akhil. From Akhil, he is asking, sir, can you please tell about teardrop limbs and curved distal end is formed why? For Viva, how to answer?
We just told you.
Let me see if I can call up my screen outside. I think there may be one picture that hold on. I don't know why you want to ask this. This is seldom asked in Vivas. Unless they really want to kill you. Okay, all right. Let me try this. Okay, let me share my screen. Okay, can you see my screen?
Yes, sir.
This is if you look at it, from the end, you will see a teardrop. This is the formed by the two limbs of this. Can you see that?
Okay, sir.
Because of the curvature. So you see the hard rim, and then you see the inferior part if you're looking in this view. So a lot of people are not really sure where the teardrop is. But I believe this looks like a teardrop if you look at it from a different angle. from the anterior posterior. This is looking at directly from lateral to medial.
And it's a overlapping shadow of that which is at the level of the medial wall of the acetabulum, which is what is seen radiologically as the teardrop. Okay, so I think if you explain that to the examiner, he'll be satisfied. Should be. Unless.
Yeah, I think it's quite informative, sir. And most of the confusion we have cleared. And few of the questions which we will cover in our next talk, like what are the approaches of us in case of a spur sign and all. In the few of the next talk, we will cover it. So,
Okay, great. Thanks.
Thank you so much, sir.
So next week we are back on Tuesday, okay?
Tuesday, 7 p.m.
Sure.
Yes.
Okay, great.
Okay.
About this today.
See you. Good night.
Good night. Good night, everyone.
Thank you, sir.
Thank you.
Thank you so much, sir.